Why do we talk about it? So at the end of the course, we'll be able to define abortion, explain magnitude of abortion, to discuss legality of abortion law and safe abortion in Rwanda, to identify the causes and risk factors of abortion, classify abortion, identify differential diagnosis of abortion, manage abortion based on its classification, identify uterine evacuation methods, and most importantly, provide post-abortion care. Let's start with definitions. So what is abortion? Abortion, also called miscarriage, is termination of pregnancy before viability. And this word viability has to be well defined. In the US, for instance, abortion sometimes is defined as termination of pregnancy at the gestational age less than 20 weeks or a birth weight less than 500 grams. In most developing countries, abortion is defined as termination of pregnancy before even 28 weeks or birth weight less than 1 kg. What is happening in Rwanda? There are no studies yet, but we used the WHO definition. So abortion in Rwanda and in most African countries is referred as termination of pregnancy before or at age of 22 weeks with a weight less than 500 grams. The reality is that viability depends on various factors in each country. So is it a really big problem? What is the magnitude of the problem? Globally, there are more than 200 million pregnancies annually, but more than 40% of them are unplanned. So currently, there are almost 56 million abortions that occur every year. And among them, 50 million only in developing regions, and 6 to 7 million only in developed countries. You can see on the table here that abortion occurs worldwide. It is almost the same. The only difference is the way abortion is done. In developed countries, there are almost about 27 abortions for 1,000 women. But in some places of the world, like in Latin America and the Caribbean, up to 44. It's too much. Well, abortion, the rate may have been declining, but not really as effective as one would like. You can see from the 90s up to 3-4 years ago, it's almost the same. The line is not really declining. It's almost horizontal. In Rwanda, there have been studies by the University of Rwanda. We all know that nearly half of the pregnancies each year are unintended. And 30% of them ended up with unplanned birth or even induced. Only half of them are planned with some miscarriages. Miscarriage can happen for unplanned or planned. It's universal. What about the law of abortion in Rwanda? It is governed by the law of 2012, but it has some exemptions. And these exemptions were outlined in 2014, where in case of rape, incest, forced marriage, or when the woman's health, the fetus health is in danger, then abortion can be performed. That is the law till today. And we are obliged to respect the law. How do we classify abortion? Abortion is classified in different ways. WHO classified it in safe and unsafe abortion, and recently in less safe and least safe. Abortion can be classified based on the gestational age in first trimester or the second trimester. can be classified according to occurrence if it is spontaneous or induced, but most importantly, it is the known classification is clinical one, where we talk about threatened abortion, inevitable, incomplete, complete, missed abortion, an embryonic pregnancy used to be blighted ovum. Unfortunately, abortion can be septic or recurrent. So this is the clinical classification that is most commonly used, especially when it comes to management. What do we call spontaneous abortion? It's an abortion that is occurring without any medical or surgical means to empty the uterus. Worldwide, 15% of pregnancies are ending in abortion, and 80% of them occur in the first trimester. What is the etiology, the risk factors of spontaneous abortion? Most of the abortion that happen in the first trimester are chromosomal abnormalities. It's very important to know about this one because women will feel guilty, and it is our role to really explain to them that it is not their fault. There may be some maternal factors, but here I emphasize that it is useless to go and do the famous torch lab investigations. Women can have abortion because of infection, because of endocrine disorders, some cardiovascular diseases, or even malnutrition. Drugs may be also risk factors. Alcohol, caffeine, radiations, these are known. What about paternal factors? There are no really studies, but age seems to play also a role. How does abortion happen? We talk about mechanism of abortion. There are 3 stages. Always abortion starts with hemorrhage that occurs in the decidua basalis. Then the product of conception are partially or wholly detached. Then they become like a foreign body. And finally, they are expelled through the vaginal canal. Well, any woman presenting with bleeding or pelvic pain doesn't have abortion. We have to talk about differential diagnosis and think about it. Think about ectopic pregnancy, think about molar pregnancy, think about simple local lesion that may make the woman bleed or feel pain, and also cervical polyps. As I stated at the beginning, our talk is about post-abortion care. So how do we manage abortion? As we said, we use the clinical classification. Treating abortion is one of the most important and very common. How do we treat it? Usually when it is treating abortion, you really don't need any medication. We tend to give medication when it is not necessary. Advise the woman, make a good examination, reassess if the bleeding is severe or not, look at the viability of the fetus, and if everything is okay, you can just counsel the woman and treat any anemia or if in a hypovolemic shock. What about inevitable abortion? First of all, what is inevitable? It means that the woman have severe vaginal bleeding, the products of conception are not expelled, but she's in severe pain, and there is effacement and the dilatation of the cervix. Membranes usually are ruptured. So these women, if she is less than 12 weeks, it's better to plan for evacuation. If not, misoprostol can be used and evacuation done if not completely evacuated. It's very important to ensure a follow-up after treatment. What else can you do? If the pregnancy is more than 12 weeks, then it's better. You can use oxytocin, but I urge you to refer the patient to a tertiary center where D&E, dilatation and evacuation, can be performed. Don't forget to give antibiotics for prophylaxis. The most common form of abortion is incomplete, where part of the products of conception have been expelled, others are retained. Women present with placental tissue in the uterine cavity, cervix is open and products of conception are visible or palpable, and she has pain and a profuse bleeding. If she comes and she's less than 12 weeks, this woman may need to be evacuated, and usually we use manual vacuum aspiration, MVA. If you are comfortable and you have electricity, you can use EVA, but you make sure that the uterine cavity is emptied and a follow-up is indicated. It is very important that all of you be acquainted with the misoprostol only regime from FIGO. This is what we have in Rwanda. We don't have mifepristone yet, but the regime we have is misoprostol only, and doses are here outlined according to the ages. In case we have mifepristone, there is a new protocol which can be used up to 70 days from the last menstrual period. I urge you to read about it and be acquainted with the different doses. If the patient comes with incomplete abortion and is greater than 12 weeks, sure, you can use oxytocin to try to complete the abortion, or refer the patient for dilatation and evacuation in a better center. The last one, and simple, is a complete abortion. Here the woman has expulsed all the product of conception. She may present with scanty vaginal bleeding, with mild cramping. What you need to do is just to be sure that the uterus is empty and the woman is stable. She may not need any other treatment. What about missed abortion? Missed abortion means that the fetus is dead but was retained in the uterus. Women may not present with severe distress, may present only with symptoms of pregnancy which have regressed, some persistent amenorrhea, some brownish vaginal discharge, and the uterine size smaller than normal, and the uterus is heavy. Usually the diagnosis is made by ultrasonography, where you see product of conception inside the uterus. The management is to counsel the woman for uterine evacuation, but sometimes because you don't know for how long it has been there, you may need to do a clotting profile before you perform evacuation. One of the worst situations is the septic abortion. Septic abortion is any type of the abortion complicated by any pelvic infection. Don't try to look for the etiology. It is always polymicrobial. The woman will present with fever, shivering, restless, with abdominal pain, vaginal discharge which is malodorant, low BP, tachypnea, tachycardia without systematic symptoms, and pain when you try to examine the patient. Cervical motion is very common. Unfortunately, she may present with peritonitis. So how do we manage this one? The most important thing is fluid resuscitation, broad spectrum antibiotics, and uterine evacuation. Now, which method may be best? From the beginning, I tell you that there is no best method. It depends on the user. So if you know to use one method, try to use that one. It depends also on the safety, the woman's clinical condition, and also her preference. So we can use medications, we can use electrical vacuum aspiration, manual vacuum aspiration, or a foot pump. Any of these methods can be done in good hands if you are trained to. Now, the most important thing is to do it in a safe way. On this diagram, you can see that in developed countries, it is done in a safe way. Unfortunately, in Africa, it is still done in the least safe way. What does it mean? Safe, it is done by a well-trained health professional in an environment that is aseptic, using correct instruments. Less safe is done probably by a well-trained health professional, but in an unsafe environment. And the least safe is done by persons who are not trained and we are not using correct methods. The consequences of unsafe abortion are really dramatic. Every year, 68,000 women die because of that, and that means 8 women per hour. Unsafe abortion can lead to different complications, as you can see, and it's not very rare that we see images like this one. Women presenting with bowels outside of the vagina and necrotic. Sometimes they end up by dying. So, performing abortion care is one thing, but these women also have bad feelings, so they need counseling. Counseling about what? About what happened, what you are going to do, and what about their future sexual and reproductive health. If she decides to terminate the pregnancy, you will need to be empathic with her and to keep her confidentiality. The procedure to choose, to use, you have to discuss with her very thoroughly, explaining the side effects and obtaining a consent form. Here is a summary of what we think to do. Treatment of the abortion, counseling, family planning in the next future, other reproductive health services, and really her community. This is the time you may see that woman for the last time or first time, so it's better to talk about it. I'm ending my presentation with a very small summary. Any woman who is seeking for care for abortion can go everywhere, can go to the pharmacist, to the auxiliary nurse or midwife, to the midwife who is qualified, or the doctor. We always recommend women to seek help from qualified professionals. Don't tell them to go and look for the pharmacist. Thank you.